So how the diagnosis is established? So you do a radiographic appearance. You can see that there is a lytic appearance here in the diaphysis in the proximal shaft, and then there is a pathologic fracture. You do a MRI or CT and evaluate for the metastatic disease. So for lung, you do the CT chest. For other metastasis to bone, you do the FDG PET or you do a radionuclide bone scan. Bone marrow aspiration and biopsy, very, very important. From at least 2 sites, you will have to take the bone marrow aspiration and biopsy. And to see the response to therapy, we evaluate through FDG PET. Differential diagnosis, of course, osteosarcoma, even LCH, other lymphomas of the bone will come. Osteomyelitis also, because this more often I told you, Ewing sarcoma will have this systemic symptoms, fever, fever, weight loss, raised inflammatory markers, and you see there is a focus in the bone. You will definitely think of acute osteomyelitis or a chronic osteomyelitis, isn't it? So osteomyelitis also is a differential diagnosis for Ewing sarcoma, and of course other sarcomas you will keep in mind. So how do you do the diagnosis? How do you establish the diagnosis? You need a biopsy, and that biopsy is done by the treating surgeon. So what about osteosarcoma's treatment? You do a pre-op chemo, surgery, chemo. Here it is again chemo, pre-op chemo, surgery, chemo, plus what happens here? Radiation. Very, very radiosensitive tumor. Okay. And chemotherapy agents vary. Here there is no mention of methotrexate, where here vincristine is added. Doxorubicin again it is given for Ewing sarcoma. More agents like cyclophosphamide, ifosfamide, etoposide are also given. So just don't forget that this is a very radiosensitive tumor. So chemotherapy is included as a part of the treatment. And but what happens when you do a local radiation? It predisposes for second malignancy. So that is also there. What about prognosis? Prognosis is mostly similar to the osteosarcoma only, but when there is a metastatic disease at diagnosis, it has got a very bad prognosis. So this is a comparative head-to-head comparison of osteosarcoma and Ewing's sarcoma. We will just go through this and then complete this presentation. So both osteosarcoma and Ewing's tumor are most commonly seen in the second decade. Ethnicity, there is a slight change. Ewing's tumor is mostly seen in the white population. It is rare in blacks. And the male predilection, boys, it is more common, 1.5:1, 1.5:1. So boys, male is to female. The ratio is similar both in osteosarcoma and Ewing's tumor. Predisposition is most often for osteosarcoma. We saw the Leslie-Fromeny syndrome, Diamond-Blackfan, all these, and the long-standing bone conditions, Paget's or enchondromatosis, they can undergo a malignant transformation. But whereas in Ewing's, there can be familial predilection. I told you one translocation that is there. Apart from that, not much of a predisposition. Site, very importantly, osteosarcoma is seen in metaphysis and Ewing's seen in diaphysis of the long bones. Ewing's, especially the site is other flat bones are present, and it can be seen in soft tissues, retroperitoneum, esophagus, adrenal kidney, anywhere Ewing's sarcoma can be seen. So presentation, localized pain, swelling, limp, this is what is occurring. Pathologic fracture, this is what is occurring in osteosarcoma, whereas Ewing's family of tumors or Ewing sarcoma can present like your osteomyelitis. Fever, inflammatory markers are raised, palpable mass can be present. Radiologically, osteosarcoma, more often there is a sclerotic destruction. Here it is primarily there is a lytic destruction. And coming to the metastasis, it is only lungs and bones in osteosarcoma. Here lungs, bones and bone marrow in Ewing's tumor. Treatment, pre-op chemo, surgery, and then continue with the chemo. Here chemo, surgery, along with that there is radiotherapy, role of radiotherapy. It is a very radiosensitive tumor. And the outcome is more often similar. If there is no meds, 70% it is cured. If there is meds, the survival rate is very, very less, very, very poor, 20% or even less than 20%. There is a chance of survival in malignant bone tumors. Okay, so with this we come to the end of discussion on bone tumors. I hope all the points were easily understandable. Thank you so much for your patient listening.